Toronto Dementia Research Alliance's education session on brain health and dementia. I'm Steph Fauquier, a member of the TDRA's Lived Experience Committee. I faced the harsh realities of Alzheimer's disease firsthand, as my beautiful, amazing mom was diagnosed with this challenging disease. I'll share more about our journey later on. We're thrilled to have you join us today at the Center for Addiction and Mental Health, CAMH, on this promising day dedicated to understanding, discussing, and exploring dementia, research, care, a topic that is so critically important. For those new to our events, the Toronto Dementia Research Alliance, TDRA, is a collaboration among the University of Toronto and the 6 leading academic hospitals in the Greater Toronto Area. TDRA's goal is to enhance the connection between basic science and clinical research with the aim of improving our understanding, prevention, and treatment of dementia. To achieve these goals, TDRA engages in numerous cross-institutional initiatives, including organizing educational events like the one you're attending today. Our session today is taking place at one of TDRA's member sites, CAMH, which recognizes the land we're on. CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805, with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Today, from 10 to 2 p.m., we have a lineup of exceptional presentations, led by esteemed experts in the field. We think you'll find it exciting. On our agenda, we have real stories, real impact. So hear from a care partner and someone who's currently living with dementia about their dementia journey. Their story opens our day, setting a heartfelt tone as we explore the human side of dementia care. Demystifying dementia. Ever wondered what really causes dementia and what you can do about it? Dr. David Tang-Wai has some enlightening answers that might surprise you. Mental health meets brain health. Dr. Fischer will navigate us through the complex interplay between mental health and dementia and what's on the horizon for treatments. Inclusive health for all. Dr. Yana Lunsky shines a light on how we can support aging adults with developmental disabilities. It's about making brain health accessible to everyone. Sleep well, think well. Discover the secret link between sleep and brain health with Dr. Andrew Lim. Spoiler, good sleep is a big deal for your brain. Engage your senses, protect your brain. Ready to use your senses to fight dementia? Dr. Allison Sekuler will show us some lifestyle tweaks that can make a big difference. And why your role in research matters. Dr. Mary Chiu is here to inspire us with reasons why joining in on dementia research is crucial and how it can lead to breakthroughs in advancing our understanding. And there's more. Enjoy interactive talks, a brain-boosting exercise break with Canoku, and connect with experts over lunch at our exhibit tables. So before we begin, a few housekeeping notes. Can you hear? Is this better? Okay. Sorry. Yay! Okay. So a few housekeeping notes. We have a seamless speaker flow, so enjoy our fantastic speakers. We'll introduce themselves, so you'll always know who's talking. You can read more about each speaker in the registration packages you picked up. You're in for an enlightening ride from one presentation to the next. Our lunch details. So hungry for knowledge and food. Lunch will be set up in the room just to the right, so feel free to grab your meal and bring it back to your table. Let's mix nourishment with knowledge. Meet our exhibitors. During lunch, our exhibitors will be ready to chat in the hallway, so don't miss the chance to stop by and dive deeper into the world of dementia care and research with them. And finally, finding your way. If you need a break, washrooms are just outside. Take a right or left and look for the signs. If you need to step out during the presentation, please do so quietly to keep the focus on our wonderful speakers and presenters. I'm sorry that you missed the first part. So hopefully you can hear me better now. Okay, so my care story. Like I said, I'm Steph, and this is my story. A few years ago, my sister Claire called me and asked me if I noticed any changes in our mom. I had, but I desperately didn't want to admit it. I was in denial, choosing to believe nothing had changed. Our mom is intelligent, super sharp, and able to keep many balls in the air. We noticed it changed when mom repeated the same question many times over. This unfortunately was the beginning of our new adventure with Alzheimer's disease. Alzheimer's disease is an irreversible progressive brain disorder that slowly impairs memory and cognitive abilities due to the death of brain cells and the breakdown of connections. Alzheimer's is the most common cause of dementia, accounting for 60 to 80% of cases. The progression and rate of decline vary widely, making each case unique and complicating the search for effective treatments and a cure. Unfortunately, my mom, Robin, passed away 10 weeks ago at the young age of 72. Sorry. I didn't think that would make me tear up. Sorry, one second. I'm incredibly lucky. I have the world's greatest mom. I won the lottery with her. Robin is an accomplished surgeon, remarkable parent, and devoted friend. My mom is a proud Albertan. She grew up in Spruce Grove, population 500. She attended the University of Alberta for her Bachelor's of Science and MD, and then completed training in general surgery at the University of Toronto, colorectal surgery at the Cleveland Clinic, as well as training in clinical epidemiology at McMaster University, before joining the faculty at the University of Toronto. She is a fellow of the Royal College of Physicians and Surgeons of Canada, a fellow of the American College of Surgeons, and a fellow ad hominem of the Royal College of Surgeons of Edinburgh. She is a diplomat of the American Board of Surgery and the American Board of Colorectal Surgery, and she holds many other fellowships around the world. She was recently made an Officer of the Order of Canada, an honor so worthy of her. To say she had a prolific career is an understatement. It was no secret that my mom's career and family are her two biggest loves in her life. She always made a point of that. I am the youngest of two daughters. As a family, we've had many adventures, made many memories, which created a close family bond. We traveled the world together and spent dreamy summers at the cottage. On Valentine's Day each year as kids, we were greeted in the morning with a special card and chocolate that our mom had left for us. We celebrated Halloween in the most beautiful handmade costumes. We likely drove our mom crazy, changing our minds in the months and weeks leading up to Halloween. We spent Saturday nights dancing in the kitchen to a favorite radio program called Saturday Night Oldies. This instilled a love of cooking and entertaining. Our family life was so rich until it wasn't. If someone asked me to write the story of my life, never in a million years would I have thought Alzheimer's disease would be a major plot line. Naively, I thought that my mom would be like the United States Supreme Court Justice Ruth Bader Ginsburg, who enjoyed her life's work until the end. When my mom was diagnosed with Alzheimer's disease, it was and will remain the worst day of my life. Despite the sadness, I knew I didn't want to stand around watching and waiting. I felt compelled to act, and I turned this new reality into a positive. I decided to create an initiative called Race with Steph. I had the bold vision and idea that I would race across Canada to raise money for research, create a conversation, and spread awareness for this terrible disease, and build community along the way. To me, there's really nothing more uniquely and proudly Canadian than racing across this spread out country, bringing communities together. Over 4 months, from May 28th to September 17th, 2023, I completed one triathlon in each Canadian province. That's over 500 kilometers of racing. Triathlon, for those unfamiliar, is swimming, biking, and running in succession, with distances varying depending on the race. The shortest time between races was 5 days, and the longest stretch was 2 weeks. I had a stretch where I raced 4 consecutive weekends. Race with Steph had its physical demands, but really it was the logistics and planning that were much more demanding. Over 4 months, I took 16 flights and traveled more than 32,000 kilometers. I assembled and disassembled my bike 14 times in order to transport it on the plane with me. I worked throughout this challenge, meaning I was at my corporate job through the week and flew out on Thursday or Friday to race on the weekends. We luckily avoided any major snafus. I did, however, break my toe during my first half Ironman coming out of the water, stubbing it on an exposed tree root. Unknown to me that it was broken, I continued on completing a 90-kilometer bike and a half marathon. It's amazing the power of adrenaline. Fortunately, I had 3 weeks until my next race and ample time to make a full recovery. I'll just say the picture on the right is me at the finish line of race number 3 with my mom, Robin. This was a really special race because this race was 20 kilometers from her hometown of Spruce Grove. So it was incredibly special to come through the finish line and seeing her. And then the other 2 are pictures from Newfoundland. For me, I'm most proud of my mom. She came to 7 of my 10 races. As I rounded the corner towards the finish line, I always looked for her. I would see her with a big smile on her face. No matter the physicality and the obstacles to do this challenge, I would do Race with Steph 10 times over for my mom. She was so proud of me and what we were achieving together. I created Race with Steph not only to honor my mom, but to recognize all of those impacted by the disease. Alzheimer's disease quickly strips you of your dignity, autonomy, and your sense of self. It is not only one of the diseases we fear the most, but carries a lot of stigma, social isolation, and shame. I thought by sharing our story, we could help reduce the negative connotation. If even this scion of science, medicine, and intellect was susceptible, then who else could be? What a powerful way to humanize an inhuman disease. Throughout Race with Steph, I repeated a maxim when I was running or needed an extra boost. I told myself, many small steps lead to big outcomes. A maxim for courage, discipline, and persistence. At times when that maxim didn't work, an expletive did the trick. When my mom was first diagnosed, I didn't know what to do. I knew I had to do something. I took that first step with my idea. The discipline and persistence powered the steps that followed. These small, deliberate steps do lead to big outcomes. I believe this motto applies to how we think about our brain health. Alzheimer's disease disproportionately affects women by about 2/3, and the brain changes 20 or more years before symptoms manifest. We know that by maintaining a healthy diet, regular exercise and activity, mental stimulation, social engagement, high-quality sleep, and removing vices supports a healthy brain. I believe if you start showing up for yourself, it is the repetition of doing something repeatedly where you start to see the results. It might not be immediate. Be patient, stick with it. Sorry, instant gratification. As for Race with Steph, I'm so proud to say that we raised more than $850,000 and created the Dr. Robin McLeod Research Scholarship at the University of Toronto for research in neurodegenerative disease. Thank you. Thank you. We're on our way, hopefully, to $1 million. That's our goal. And so it means that every year, in perpetuity, we will be able to fund 1 to 4 graduate students in the study of neurodegeneration, which obviously we're all here for it, and it's very important. Race with Steph will continue on. This is only the beginning. We are champions for brain health. We hope to inspire others to take action along the way. For more information and to follow along, you can go to our website, racewithsteph.com, or you can follow me on Instagram and other social media channels with the same name. We would love to have you join the community. Now, on to the main event. We're set for a day filled with learning, sharing, and community building. Thank you for being here to support and contribute to this important dialogue on brain health and dementia. Let the learning begin. And the next presenter is David Tang-Wai.
Well, good morning, everybody. My name is David Tang-Wai. I'm a neurologist at Toronto Western Hospital, and I co-direct the UHN Memory Clinic. And Stephanie, thank you for your story. Yeah, try not to get hit by the thing. And I think that's why we're here. Why I've spent 30 years now of my career trying to do something about dementia. And what can you guys do about it? This is common for me to hear. I do this day in, day out. And I hear people come to me and say, well, I'm becoming more forgetful over time. And it doesn't matter what age, doesn't matter what gender, doesn't matter what cultural background. And these individuals who come to me, they have concerns and worries. Am I beginning to have Alzheimer's disease? Is this normal aging? But there's no one in my family who has it. How can I get it? Will I be a burden? Will I be dependent? And I'm fearful. What can I do about it? Got it. Thank you. These are my disclosures. I have no financial disclosures. I've got pop-ups all over the place. I am a member of the Hydrocephalus Canada, part of the Medical Advisory Board. So what is dementia? When I teach this to my students, I simplify it to a simple mathematical addition equation. Dementia is defined as some change or decline in thinking and or behavior. It's also associated with a change or decline in someone's ability to do their day-to-day activities. When it's shopping, cooking, cleaning, planning, doesn't matter. And if those two conditions are present, we call this individual, unfortunately, they have a dementia. And the change in thinking and behavior could be anything. It could be memory. It could be language or trying to find the right word or forgetting what words mean. It could be finding a way around familiar places. It could be planning and multitasking. It could be, how do I put these things together when I used to be able to do it before? It could be I'm becoming more I don't care attitude, or the reverse, the opposite, is disinhibited, being not able to have a filter. But dementia is more complex. Behavior is more complex. Cognition is more complex. And we now have a spectrum from normal to dementia. And we divide each stage, for the lack of a better term, into subjective cognitive impairment, where someone is knowing that there's something wrong, there's something is different about me, but when I see my doctors, everything is fine. But maybe these individuals are the earliest stages of something going on, of a neurodegenerative process. Then we have individuals who have something called mild cognitive impairment, where there is something going on, and either they themselves know or their partner is aware. There is something that we could see on testing and maybe imaging, but their day-to-day activities are still normal. They're still able to do their day-to-day, and we call it MCI. And at the farthest extreme is dementia, where there is a problem with memory, thinking, or behavior. People are aware of it, they see it, they witness it. There is a change or a decline on testing, and their day-to-day is impaired. And when they satisfy that condition, we call it dementia. And people ask me, well, why is it important to know this? Well, it's about risk. We know that people with mild cognitive impairment have an increased risk of converting to dementia, and that risk is roughly about 7 to 15% per year. That means if you took 100 people with mild cognitive impairment, in 1 year, 7 to 10 of them will have developed dementia or progressed to dementia. Unfortunately, we don't know who. We can identify in that 100 people who could do it or who will do it. But after 10 years, pretty much everyone will change. And now we need to know who are in these categories, because our treatments are going to reflect these categories. So let's address some of the myths and realities about dementia and Alzheimer's disease. So a common thing is, as my dementia gets worse, it leads to Alzheimer's disease. In the end, that's false. Alzheimer's disease is a cause of dementia. It is a cause of those changes, which we'll see in the next slide. All dementias are the same. No, they're not. Each one of those dementias, each cause, whether it's Alzheimer's disease or frontotemporal or something else, have a different course, have a different line of treatment. You may want to try some medications for some and are forbidden in others. So knowing the exact cause is very beneficial. Also, as we develop new therapies to really conquer this disease, to slow it down, we need to be very targeted about what we're dealing with. The last thing is, dementia is a part of normal aging. It is not a normal part of aging. How many people have said that? How many people have heard about that? It's more common as we get older, but I have 50-year-olds, unfortunately, who have Alzheimer's disease. I have 40-year-olds who have Alzheimer's disease. It's not a normal part of aging. There are various types of dementias. Dementia is just that term, what we call an umbrella term, to describe a change in memory thinking with a change in ability to do day-to-day things. But up there, we see various causes. We have Alzheimer's, vascular disease, dementia with Lewy bodies, which is tightly associated with Parkinsonism, frontotemporal, which has often a change in language and behavior. And we have mixed diseases, where you can have two things happening in the same individual, like Alzheimer's and vascular disease is very common. And what makes them unique is what they present with. What is the story of their dementia? How do they start? What other symptoms comes along? How do they progress? And that's how we figure out what type of dementia we're dealing with. And the most important part is we know, for now, if we know what the cause of it is, we are beginning to have therapies. Oops. And this is one of them. We're hoping, this is an antibody, it's called lecanemab, is the generic form. Leqembi is going to be the trade name. This is one of the first new therapies in over 30 years for the treatment of Alzheimer's disease. Unlike the current therapies like donepezil or Aricept, which only handles the symptoms, this will attack the disease itself. It's designed to remove the amyloid plaque from Alzheimer's disease. So we need to know who actually has it and not be mistaken for something else. That's why it's important for us to know what's going on. Unfortunately, it is not a cure. It's the first step towards a cure. It's the first generation of this new field. And we're expecting Health Canada to actually approve it shortly, sometime this year. And we'll be able to hopefully roll this out. But unfortunately, dementias progress over time. And what I get asked about frequently is, well, how do they progress? What's going on? How does it do that? Well, if I look at all the dementias, with the exception of strokes causing dementia, they all have this very common idea. There is an abnormal protein. We all have this protein. But at some point in our lifetime, it changes. And when it changes, it likes to clump together in a nerve cell. And when it clumps together in a nerve cell, it makes that nerve cell dysfunction, makes it aberrantly fire, may not work at all. And then it leads to its death. And then it moves to the next nerve cell, and the next one, and the next one. And there's a very particular profile for each one of them. They start in one part of the brain, and it spreads to another part, and then to another part, and to another part. That's why people don't stop in a certain stage. They unfortunately progress. This is the gross reason, the basic reason for it. How do we determine dementia? What do we all do when that's in one of our academic clinics or in the community? We need the story. Story defines what's going on. We want to know the first to the second to the third to the fourth. We want that time course. It's very important for us. We'll do a thorough examination. That's why we spend an hour and a half usually with one of us to 2 hours. We want to know, what is this individual's memory doing or thinking? And often it's not what they get right, in my opinion, that's important. It's what they get wrong. And how is it that they get wrong? Because I can figure out what pathways are not working. What is their neurological exam, their physical exam, and their psychiatric or mental health? Then we do CTs, MRIs. We want to know what the brain actually looks like. We want to be sure there isn't something that could be mimicked, that could be treatable, like a vitamin deficiency or a kidney problem. And now, with this new age, we're starting to get very specific, what we call biomarkers. These are either blood tests, PET scans, spinal fluid, unfortunately, and actually tell us what the actual cause is. And we're fortunate now for some institutions, because the government's trying to let us try this out, is to have what we call amyloid PET. It's a picture of the brain, and we can literally picture in the brain where the Alzheimer's actually is. But unfortunately, it's only specific for Alzheimer's disease, and it will not show the frontal temporal. It will not show the vascular, but it's a first step towards that goal. Here's another myth. MRI can diagnose dementia. Unfortunately, I wish it did. It would make my life so much easier. But it doesn't. You need every piece of information available to you to make that diagnosis. The MRI does not picture the small amyloid plaques, that's microscopic, or the tangles, also microscopic. So what can we all do? How can we slow this down? How can we prevent it? How can we delay it? Well, I've kind of put out to here what it takes. It takes decades. We heard the beautiful story before. It takes decades to develop frank dementia. And now we're noticing there's some genetic factors. There's vascular factors, the things that cause stroke and heart attack. If we can address those, we can reduce our risk for developing dementia. There's environmental factors as well. We know that low education, we know that not even exercising, being isolated, not interacting with people, poor hearing, head injury, poor diet, too much alcohol, all contribute to this. And as I said, it takes years to do this. But the earlier we start to tackle these issues, these risk factors, the less likely we're going to develop it. It's not going to be perfect. It's be less likely. Another myth, dementia is always genetic. Not always. There's some people who do have certain genes which increases their risk of developing dementia or can cause it. But some of those, you're not guaranteed to develop it. ApoE4 is a good example for Alzheimer's. You may have it, it increases your risk, but you're not guaranteed to get it. And with the previous slide, there are other reasons that we may get it. And there's one reason overall that we probably were going to get it. It's called aging, and we can't escape that. For centuries, people have been trying to find the fountain of youth. I'm still looking for it. If you find it, share it with other people, please. But we know this works. We know the prevention works. This is the 2020 version now, and there's a new 2024 version coming out in a few months of what can we do to prevent dementia. It's listed all there. What I tell my patients is I don't care, listen to midlife and late life. I actually don't think it should be separated personally. I mean, why would you want to wait later life to tackle smoking? Like hell, do it early. In fact, don't even start, you know? And the theoretical risk reduction is about 35–40%. That's impressive. And we do see it. The rates of dementia is declining because of healthier lifestyles in the last couple of years. So there are studies to now show that. I mean, most of my talk about what can you do about dementia is already in today's program. Makes my life so much easier. My colleague, Dr. Fischer, is going to talk about mental wellness and how it affects us. My colleagues this afternoon or later this morning will talk about sleep hygiene. Poor sleep increases your risk of Alzheimer's disease. So does sleep apnea. Exercise is important, not only from a physical perspective, but also your mental perspective. And then lifestyle changes. So my work is already cut off. Sorry, you guys have got to stay here all day, but I mind. But this is one we could do. It's called the MIND diet. Used to be the Mediterranean diet, but they added the heart aspect to it. It's called the MIND diet. And it's not what you eat. I mean, the people often think, well, for the Mediterranean diet, But I have my olive oil. I have my leafy greens. Yeah, but if you look at the actual diet, it's a pyramid diet. The bulk of one's diet is leafy greens, legumes, vegetables, grains. That's the base of the pyramid. At the very top of the pyramid is red meat. And that's like once a month, and it's about whatever you can fit in your hand. Slightly below that is chicken or poultry, and then slightly below that is fish. So it's not what you eat, it's also how much. What happens if you have dementia? This is what I tell my patients to do. Most people think that their life is over. No. Live your life. Continue doing what you want to do. Do you have a bucket list? Do it. I mean, I'm going to have safety issues in there as well. Don't stop living. I've had families who will say, okay, now we're going to go out to that trip. Do it. Here are some safety precautions. Do you have plans? Have you made your wills? Have you made your power of attorney? We talk about what do they want to do. My follow-ups are very different. My follow-ups at some point become, hey, how are the kids? How are the grandkids? And get to know the person. But you don't want to stop living. You stop living, you start dying. And that's, for me, very important as a physician, is to maintain their health. And that health is everything. And for the partner that's with them, how do you support them? How do you cope? Through education, picking up a phone, counseling. The recommendations I said earlier also apply to people with dementia. Address the smoking, address the vascular risk factors, address everything else, address mental illness as well. And with that, that's going to be my last point. Continue on living. Thank you. So thank you very much for your attention. I'd like to introduce Dr. Corinne Fischer, geriatric psychiatrist at St. Michael's Hospital. Thank you for your time.
Thanks. That was great, Dave. Thanks so much. It's really a pleasure to be here today and see such a crowd full of people. It's really quite amazing. So I want to thank people that organized this event. It's fantastic. So I'm Dr. Corinne Fischer. I'm a geriatric psychiatrist based at St. Michael's Hospital here in Toronto, and I run the memory clinic there. Okay, so here we go. So this is me. So I don't have any, I have a few relevant disclosures, and they're listed there. So I wanted to start with some basic questions that we can maybe reflect on as I go through my presentation. I won't ask these questions, but just think about them. Does having a psychiatric disorder increase your risk of dementia? So I often get asked that question. Does treatment of the disorder matter? Does being on an antidepressant reduce your risk of dementia? And what percentage of patients who have dementia will develop behaviors? And are there any effective treatments for those behaviors? So one of the things I want to emphasize is that mental health changes can occur both before and after a dementia diagnosis. If you have a mental health diagnosis, that does elevate your risk of dementia. We don't know by how much, but it is one of the many risk factors. So with depression, it can actually even double your risk if it's midlife depression. And it's probably even higher if you have a psychotic illness. There's a broad range of neuropsychiatric symptoms that are associated with dementia. So as people dement and progress in their dementia, they can develop symptoms they've never had before in their life. So they can become anxious. They were never anxious before, but they're anxious now. They can become depressed. They can become psychotic. And they can become agitated and aggressive, things that they never were before. So this is just an outline of I think Dr. Tang-Wai alluded to this. There are many risk factors for dementia, and you can see depression being one of them. But depression can be associated with a number of other things that can elevate your risk of dementia. So, for example, pollution, air pollution, living in an urban area, having a head injury, substance abuse, often associated with mental illness, can be a risk factor. Being socially isolated, that can be a risk factor, and there's an association with mental illness as well. So exactly how does depression lead to dementia? Well, there are a number of potential mechanisms, if you will, and they're listed there. So what depression does is it increases the amyloid burden in the brain. It causes inflammation. Depression is associated, and many mental disorders are associated with enhanced brain inflammation. And then there's changes in nerve growth factors as well. And there are vascular problems that can develop as well that lead to disconnections between the frontal lobe and other parts of the brain. You get increased stress. You get increased cortisol when you have a mental illness, and that is considered negative as well. So again, I think I've alluded to this, but it's not just the mental illness. It's the psychosocial factors that may be associated with having a mental illness. So poverty, in some instances, substance abuse, exposure to pollution, unemployment, homelessness. Again, all of these things factor in terms of the risk of dementia. Inadequate housing, poor diet, increased cardiovascular disease burden. The medications that we give to treat many mental illnesses will increase the risk of cardiovascular disease, and that's an independent risk factor for dementia. Schizophrenia, may be associated with a 2.5 to 3 times elevated risk of dementia. Now, that's not to say Alzheimer's disease exclusively. It could be mixed dementia, it could be vascular dementia, but there is an elevated risk. And again, it's unclear if it's actually the schizophrenia that's promoting this or other factors such as low cognitive reserve, cardiovascular disease, the medications themselves. Bipolar disorder, it's similar. It's about 2.3 times greater than in the general population. And it's not really clear if you treat the disorder, will that affect the risk? It's not clear. So this was an interesting expose in the New York Times that looked at mental illness and the effect in terms of promoting the risk of dementia. And they referenced this very interesting paper that was published in JAMA Psychiatry. And this was actually a very interesting study. It looked at a large cohort of patients in Sweden, about 1 million patients actually. And they looked at a registry from 2000 to 2017. And what they did was really interesting. They looked at the risk of, or the rates of psychiatric diagnosis in the period both before and after a dementia diagnosis. And in that large cohort, about 1/3 of patients developed dementia. And there was a significantly increased likelihood of a psychiatric disorder being diagnosed in the 3 years before diagnosis. That peaked at 1 week after diagnosis, and then it went down. Because once you have dementia, people are less likely to diagnose a psychiatric disorder. So similarly, in terms of medications, they looked at the utilization of things like antidepressants, and that increased in the 2 years before diagnosis, peaked at 6 months after the diagnosis, but it actually persisted for up to 5 years after the diagnosis. So most people who sort of started off with an antidepressant, they remained on it for a period of time. And this is not just Alzheimer's disease, this is all forms of dementia. So this is a little bit hard to see, but the graph on your right shows what I just talked about, the elevated risk before of psychiatric illness before a formal diagnosis of dementia, and then how it petered out afterwards. And that's for all forms of dementia, so Alzheimer's disease, vascular dementia, frontal temporal dementia, all of that. And the graph on your left, what that shows, the blue line are, the orange line are the control participants, the blue line are those that develop dementia. And you can see that those that had a dementia diagnosis, and they looked at a variety of medications, they looked at antidepressant medications, anti-anxiety medications, and so on, and there was an elevated risk before the dementia was diagnosed, and then that sort of went down as time progressed after diagnosis, but it never really got back down to the level of the control group. So mild behavioral impairment is something that I am very familiar with. I have a close friend and colleague, Zainer Ishmael, who's done a lot of really fundamental work in this area, starting back in 2016. And this is the idea that it's not just cognitive impairment that leads to dementia, but rather there's this prodromal phase where you can have psychiatric symptoms and behavioral symptoms that can be an important predecessor to the development of dementia. So there's a theory, and I think it's gaining a lot of ground, that the first symptom might not be cognitive impairment as much as it might be behavioral impairment or behavioral symptoms. And so if you develop a new onset psychiatric disorder or behavioral syndrome, you are much more likely to end up with dementia. And a lot of these patients who have these syndromes have no prior psychiatric history. So if you have schizophrenia and you become psychotic, that's not necessarily elevating your risk. But if you've never been psychotic before, and at 65 you suddenly become psychotic, that would enhance your risk. So again, this is the sort of the construct of mild behavioral impairment. There are these sort of changes in behavior or personality that occur. There's usually, and these are the different domains. So there's decreased motivation, affective dysregulation, impulse discontrol. These are people that sort of do things without thinking, socially inappropriate behavior, and abnormal perceptions, psychosis. And then for it to be mild behavioral impairment, it has to affect function in some way, social function, interpersonal relationships, ability to perform in the workplace, and so on and so forth. So, and it can't be due to something else. So if you've already got a psychotic illness or depression, that doesn't qualify. And and there's no other diagnosis driving what you're seeing. So this is a really actually interesting paper, another interesting paper that looked at this notion of, do antidepressants, are they helpful in sort of preventing dementia? Again, this is not conclusive, but it's a really interesting idea that maybe things like SSRIs may actually be protective or neuroprotective. Again, this is one study. It hasn't really been replicated, but it does sort of raise an interesting question. And in that study, they looked at about 800 patients, and these are patients non-depressed from what's called the Alzheimer's Disease Neuroimaging Initiative dataset, and they looked at progression from cognitive impairment to Alzheimer's, and then various CSF biomarkers. And what they found was that those patients who were on SSRIs, those are drugs like Prozac, Zoloft, Luvox, you may be familiar, actually decreased the level of beta amyloid in the brain. And no difference in CSF markers per se, but those that were treated for 4 years with an SSRI had a delayed onset of dementia by as much as 3 years relative to those who were not, or who were on short-term use. So that seemed to be having a bit of a neuroprotective effect. Again, we don't have enough evidence to say this is definitive, but it does raise a question: are there treatments that may be actually neuroprotective? So the flip side of having a psychiatric diagnosis and that making you more vulnerable to dementia is that when you develop dementia, you can develop behaviors that you never had before. So onset of dementia is associated with neuropsychiatric symptoms in about 80% of patients. And from what I see in my clinic, these symptoms really cause significant caregiver distress, probably much more so than having an impaired memory or even functional decline, because we don't really know oftentimes how to deal with patients that have these symptoms, in particular if there's aggression or agitation or psychosis. And they're associated with a really accelerated rate of admission to long-term care homes. We don't have a lot of good treatments. We typically borrow from the psychiatry world what works with patients who have psychiatric illness, but we don't have a lot of treatment specific to dementia. Due to, there's a concern about the use of antipsychotic medications, in particular amongst patients with dementia, because there's elevated mortality. So over time, you've seen actually a reduction in the use of these medications, which are really quite potent and may be associated with accelerated mortality. So these are the different domains, behavioral domains that we see, and you can see that some are much more common than others. So the darker green represents more severe symptoms, the lighter green are less severe symptoms. And so you see all of these various domains that can emerge as you're diagnosed with dementia: elation, eating behaviors, aberrant motor behavior, the person who really can't sit down, disinhibition, saying things without thinking, hallucinations, seeing things without that are not real, delusions, having fixed false beliefs, being very anxious, depressed, having sleep problems, people that sleep too much or don't sleep at all, irritability, agitation, aggression, and then apathy, probably the more common symptom that we see. And here you see the various symptom domains, and you're comparing here patients with Alzheimer's disease and patients with amnestic MCI, so those that have kind of the prodrome to Alzheimer's disease and those that actually have Alzheimer's disease. And you see that certain symptoms are much more common in frank Alzheimer's disease, those being delusions, agitation. You don't see a lot of agitation in patients with mild cognitive impairment, euphoria. Disinhibition, not very common again, and then some of these motor behaviors. So again, as I mentioned, over time, we used to use more antipsychotic medications than we use now, and essentially that's because we did studies that actually showed that if you use an antipsychotic in a patient who has dementia, it can accelerate the mortality up to 1.5 times that of patients not on those medications. So what have we switched to? Well, we've switched to other things that maybe aren't as, it's hard to know. Are they more effective, less effective? So there's been an increase in the use of what we call hypnotic agents, drugs like Ativan, lorazepam, and antidepressants. There's actually some fairly good evidence that SSRI medications, drugs like Prozac, can be effective. But we do need I think we need better non-drug interventions from what I've observed. So you can see this is the graph that shows a reduction in the use of the antipsychotic medications on the top and an increase in some of these other medications on the bottom over time. This is from a period from 2005 to 2015, and you can see that there's been this reduction in antipsychotic medications over time as time has progressed, and then an increase in the same time frame in things like anxiolytics and antidepressant medications over the same time frame. So one of the first drugs actually to be approved for agitation in patients with dementia by the FDA is brexpiprazole. So this is some really exciting data there, and it was based on analysis of 2 phase 3 trials, so some very good data. But again, there's a risk of mortality. So if you're going to use one of these medications, it does increase the risk of dying, and so it's a substantial concern. Well-tolerated, good safety profile, and there we go. So one of the challenges, or one of the big questions with mental illness and dementias. These are both brain diseases. Are there drugs that maybe target both disorders? Again, the anti-amyloid therapies, as Dr. Tang-Wai alluded to, they show promise. But one of the problems is that patients who had a psychiatric illness were excluded from the clinical trials. So if you had, with the exception of depression, so if you had schizophrenia or if you had bipolar disorder, you weren't admitted into the trials because of the theory being, maybe those things could already independently affect your memory. So it's going to be interesting to see, will those drugs be as effective in patients who have major mental illness? Are there treatments that maybe target both disorders? We know that inflammation and mitochondrial dysfunction are mechanisms that are common to both. So is there a role for alternative treatments? One of the things that we're interested in studying is something called photobiomodulation, transcranial photobiomodulation, the use of infrared light to stimulate the brain. And this is actually a study that we're doing, sponsored by the Weston Foundation. And you see on your right one of the devices that we're actually using, and it's something you should wear on your head. And it's we've got a 6-week trial that we're running at the moment, we have some promising, very preliminary data, but this is really something that remains to be seen as to whether or not it will work. We also have another study that we're doing looking at can we use EEGs to differentiate different types of dementia. So you can learn more about those, I think, during the exhibit hall presentation. And so there's my presentation, the post quiz, the questions that I raised at the beginning. You can again reflect on those, maybe I can go through them. So does having a psychiatric disorder increase your risk of dementia? I think it's pretty clear that that's a yes. Does treatment matter? The question is the answer is that we don't know, right? Because the studies haven't really looked at that in depth. Do antidepressants reduce the risk of dementia? Again, we're not really sure. There's one study that shows some data, but it hasn't really been replicated, so we're not really sure. What percentage of patients with dementia will develop behaviors? I think that's pretty clear, a large number, about 80-90%. Are there any effective treatments? Well, as I alluded to, we do have brexpiprazole that has just been approved by the FDA for management of agitation. So I think the future looks a little bit more promising, at least in that regard. So there's my email. If you have any questions or comments, feel free to reach out, and I'll open it up to questions.
Good morning. Nice to see a nice full room. My name is Ruth Kruger, and I work in knowledge translation at the TDRA, so welcome. We're so happy to have you here today, and we want to deeply thank CAMH for hosting us. We also want to really thank our expert presenters who've taken their time to share their great knowledge with us. The presentations so far, I think, have been just tremendous, and we're very proud to bring this event to you. And of course, thank you all for attending. I have the pleasure of interviewing Paul Lee today, and I'll let Paul tell you a little bit about himself, but first I just wanted to thank Paul so much for taking the time to come today.
My pleasure.
So Paul, why don't you introduce yourself and tell us a little bit about yourself.
Okay, I'm 71 years old. When I was 58, I suffered a massive stroke, which literally killed a quarter of my brain and left me with vascular dementia. I have several deficits. The big thing that I want to say is that I accepted my situation. I accepted the fact that I would have some difficulties, and I moved on. So I have several cognitive problems, but I live well. I use technology to help me, and that's it.
So maybe you could tell us a little bit more about some of the medical history that you went through and how you're managing at this stage, many, many years later, to live so independently.
Medical
Let's
history.
start with a bit of the medical background.
I basically was a healthy person before having the stroke. I thought I had symptoms of dementia in 2008, and my family doctor, who I knew for 30 years, called me a hypochondriac. Go figure. But I started having difficulty, confusion. I used to work in a clothing manufacturer, and I would take shirts. I was a quality auditor. I'd take shirts out of plastic packaging and measure them, but I couldn't put them back in. I'd get my coworker to do it. I ended up not being able to work because of the symptoms that I was experiencing, like confusion, etc. And that's about it.
Yeah. So I know you've got a daughter that you've talked about who lives out of town and helps you once in a while, but you've got an amazing ability to live very independently, and I'm wondering if you could share some of the secrets of how you do that.
Well, when I was first diagnosed, for the first 6 years, life was hell. I didn't go anywhere. I got panicked every time I went outside. My daughter would take me to appointments, and she basically taught me how to live again. Cooking, doing laundry, basically living again. And she would take me to appointments. Eventually she couldn't do that, and I decided I had to go. I would go to Google Map, and then I would go to Street View, and I would go up and down in the Street View, so that when I got to the address, I didn't panic. It looked familiar,
Yeah, I believe you also use Alexa quite a bit.
Oh, yeah, she's a good friend. She's very polite. She doesn't talk back, and she controls all my lights. I love technology, and it really helps me live a good life. She controls all my lights. She controls my fan, my air conditioner. It's a relief, and on top of that, I have a habit of not locking my door, and now I have it's a Wi-Fi door lock, so that as soon as I close it, it automatically locks, which is a big relief.
Maybe you can tell us a little bit about how you're involved with different community groups now.
I'm sorry?
How you're involved with different community groups. You work with CCNA, you work with on our lived experience panel.
Yeah, I'm a patient advisor with CCNA, EPLED. EPLED is engagement with people living with dementia. TDRA, Baycrest, Age Well. As a person with a lived experience and doing this for a while, they seem to think that I have something to offer. So I fooled them, didn't I? Yeah.
So why don't you tell us a little bit about your hat?
Oh, my hat. It's my signature. I'm not sure how many people can see. There's a blue hatband, and on the hatband is a flower. and it's forget-me-not flower. It was adopted by the Alzheimer's Society in 2016 to help end stigma. And I myself did experience stigma once a while ago. I've been to Kipling subway station many, many times, and this one particular time I forgot how to get out. And I asked this guy, could you, I have dementia, can you help me? And he says, yeah, sure, just go over there, follow that. And I said, okay, fine. And about 10 seconds later, I said, excuse me, can you say that again? And he says, what are you, stupid? Leave me alone, get away. And he very quickly walked away. Jerk. So anyways, the hat band, I get asked quite often what it means, or not what it means, but not asked. I'm told it's a nice hat, the fedora. I have a bigger fedora, same hat band, but it gives me an excuse to talk, and I love to talk.
So my final question to you, Paul, is you've got, I think, a new addition to your family. Why don't you tell people about it?
Yeah, I'm a grandpa. I'm a grandfather. Thank you. If I had a big screen, I could show you a picture of me wearing a T-shirt that says, great fathers get promoted to grandfathers. So, yeah, he's a big boy. His name is William, and he was born on March 23rd. Yeah, I love him. It's my first grandchild.
Thank you, Paul.
You're welcome. Thank you.
All right. Hi everyone. So my name is Andrew Lim. I'm a neurologist up at Sunnybrook. I see patients in my clinic who have sleep complaints, so difficulty falling asleep, staying asleep, problems with daytime sleepiness, and who may also have concerns about their memory. They may already have a memory disorder or may be worried about getting one. And my research program is largely focused on exactly this, the relationship between sleep and cognitive impairment. So I'm going to start off actually with a lightly fictionalized patient, but very typical of the sort of person who I might see in my clinic up at Sunnybrook. So this is Beatrice's story. So she's a 76-year-old woman who's had now 5 years of difficulty staying asleep at night, accompanied by excessive daytime sleepiness. And she's also had a year now of increasing difficulties with her memory. Okay, so she gets really tired during the day, especially after dinner. Some days she'll go to bed as early as 7 or 8 o'clock at night, but many days she forces herself to stay awake until 11 p.m. due to social commitments. She has a very busy life. She falls asleep very quickly at the beginning of the night, but wakes up a lot. So she wakes up 4 or 5 times a night, and then many mornings she'll wake up as early as 4 a.m., and she's just unable to get back to sleep, so she'll begin her day at that point. She also has been noted to snore a little bit as of late, and over the last year, she's had increasing memory difficulties, so forgetting where she placed her keys or forgetting what she had gone into a store to buy. So Beatrice has, for me, a number of questions. So she asked me, a lot of her friends have trouble with sleep as well, and she wonders whether there really is anything actually wrong with her sleep, or is this just a part of getting older? Beatrice asked, what's causing her sleep difficulties, and how can we figure this out? She's curious about her memory difficulties and whether they are at all related to her problems with sleep. And importantly, she asked, what can be done to improve her sleep, and whether improving her sleep might improve her memory and prevent dementia. So I'm going to go through each of these questions one by one. So her first question is whether her sleep really is abnormal at all. So I get this question a lot. So how much sleep do I actually need? What's a normal amount of sleep? And the answer is actually kind of more complicated than it seems. So you'll see a lot of stuff out there about needing 7 or 8 hours of sleep. And indeed, on average, many people do need about that much sleep. But the reality is some people need less and some people need more. So what I like to say is this: if you fall asleep easily and stay asleep for anywhere between 6 and 9 hours with no more than a couple of awakenings at night, and if you have no trouble staying awake all day long, even in sedentary situations, so you can watch TV, you can be in meetings, you can be a passenger on a long car ride, and you don't fall asleep, then your sleep is probably okay. But this, of course, is not the case with Beatrice here, who isn't able to sleep as long as she would like. She's probably sleeping only five hours a night, and she's waking up a ton at night and is sleepy during the day. So to answer Beatrice's question, her sleep does seem a little bit off for somebody her age. Whoops. Okay, this is actually question 2. So her second question is, what's causing her sleep difficulties and how can we figure this out? And there are bits to her story that suggest specific diagnoses. Her sleep timing suggests that there might be a misalignment of her body clock, and I'll talk a little bit about that. The history of snoring raises the question of something called sleep apnea, and I'll talk a bit about that. And as well, we know that as we get older, there are changes in our brain that make our sleep a little bit lighter and more fragmented, and that may be an issue as well. So let me talk a little bit about the body clock, these circadian rhythms. So within each of us, there's a 24-hour body clock that determines the timing of a whole sequence of body processes. And this body clock, which exists in a part of the brain called the suprachiasmatic nucleus, serves to time and align our bodily functions to the day-night cycle. This suprachiasmatic nucleus, in turn, receives input from the eye, so light is the main signal that tells our internal body clock what time of the day it is, and then it sends signals to other parts of the brain and body to synchronize them. Importantly, the suprachiasmatic nucleus sends signals to the rest of our brain that help us to stay awake during the day and help us to sleep at night. So you can see that during the daytime, there are wake-promoting signals, and during the nighttime, sleep-promoting signals. In advanced sleep phase, which might be what Beatrice has, the master clock sends wake signals too early in the night. So rather than sending wake signals at 7 or 8 o'clock in the morning, Beatrice is getting wake-promoting signals at 4 o'clock in the morning, causing her to wake up early. And then she gets sleep-promoting signals too early as well, which is why she gets so awfully tired at 7 or 8 o'clock at night. Well, what causes this? Some of these things are environmental. So if you get too much light in the morning and insufficient light at night, it can make this more likely to happen. But genetics plays an important role, and so does age. So we know that the internal body clock, as we get older, advances a little bit with every succeeding year. So the other thing that Beatrice might have here is sleep apnea. So sleep apnea is a condition that's characterized by repeated collapse of the upper airway, resulting in restriction of breathing at night. So people breathe fine during the day, but then have snoring and restriction of breathing and sometimes stoppage of breathing at night. This leads to frequent nocturnal awakenings and low oxygen levels and excessive daytime sleepiness. Now, when we think about sleep apnea, we often think about kind of like overweight, middle-aged men, but the reality is that as we get older, and especially after menopause, more and more women actually get sleep apnea as well, and it's underdiagnosed in women because of these stereotypes that we have about what the typical sleep apnea patient looks like. In fact, it's present in up to a fifth or over a fifth of women over the age of 65. Now, the third factor that we think might be at play in Beatrice here is changes in brain circuitry that accompany aging. So just like there are parts of the brain that are responsible for vision or memory or movement or other things, there are parts of the brain that are responsible for keeping us awake during the day and for keeping us asleep at night. So there's an off switch for the brain that has to function to allow you to sleep. And we've done a little bit of work taking a look at this area. It's an area in an area of the brain called the hypothalamus, and it sends signals to the rest of the brain to shut off in sleep. And what we found is we studied a bunch of folks with wristwatch devices to measure their sleep when they were alive, and then when they passed away, they donated their brains. And we took a look at this region and found that the number of cells in this region was a predictor of how well people slept. So it's lower with age and lower yet again with Alzheimer's disease. It's the number of cells in this area. And the fewer cells you have, the more fragmented your sleep is. Okay. So how do we make a diagnosis of these things? So traditionally, you guys will maybe know that we would bring people into the sleep lab, right? So you come, you spend a night in the hospital or the sleep clinic, you get hooked up to like a ton of electrodes. It's kind of uncomfortable. You get a bunch of sensors placed on your face and your chest and everything else, and then we try and make a diagnosis. But of course, I mean, there are huge downsides to this, right? It's kind of uncomfortable for anybody who's ever been in one of these sleep labs, right? It's expensive. There aren't a lot of spaces, right? It requires specialized technicians and doctors and that sort of thing. And ultimately, what I like to say about these sleep labs is they're not really a measure of your sleep. It's a measure of how well you tolerate a sleep lab, right? So the people who sleep well in the sleep lab sleep well because they can tolerate a huge amount of discomfort. So a lot of work in our group is on using wearable sensors to ask the question, can we just replace this whole business with sensors so that people can sleep at home in the comfort of their own homes and make a diagnosis this way? So we work with EEG headbands, like the Muse headband. We work with these adhesive patches to try and diagnose sleep apnea. It's like a little smart Band-Aid that you can just put on your chest and diagnose sleep apnea that way. And we work with wristwatches as well. And a lot of the effort in my group is focused on applying AI to these signals, so that instead of going to a sleep lab and then waiting 2 weeks for somebody to analyze the results, you put on a little Band-Aid on your chest and you get the result the next day. Instead. So I think we can make a lot of progress in sleep diagnosis. So what about Beatrice's memory difficulties? So it does turn out that people with sleep disturbances like insomnia or sleep apnea do have a substantial increased risk of developing dementia later on in life. We've done a little bit of work in this regard. So we studied 700 people. We measured their sleep with wristwatch devices and then took a look at who developed dementia over time. And you can see the dark line here is people, this is the risk of dementia. The dark line here is people with really kind of fragmented sleep who wake up a lot at night. This is people with great sleep who wake up relatively little. And you can see that the people with really fragmented sleep at baseline have a higher risk of developing dementia over time. We have a lot of interest actually in our group in dementia prediction, and one of my students, one of the medical students, Julie, who works with me, has taken a look at these actigraphy recordings, these wristwatch recordings, and developed a AI-based model to try and predict who will develop dementia over time. And what she's found actually is that this model, if it predicts that you are unlikely to develop dementia over this sort of 6-year time span, you really are very unlikely to develop dementia, whereas people who have a certain pattern of sleep-wake activity, where the model says you're likely to develop dementia, do have not 100% risk, but obviously a substantially greater risk of developing dementia than those without this particular pattern on their wristwatch devices. Why does this happen? So this is like a huge area of focus in my research group, what sleep does to the brain that leads to dementia. I'm not going to go into this because there's a lot of technical details, but suffice it to say that we've shown in my group that people with disrupted sleep are more likely to develop amyloid plaques and neurofibrillary tangles, so the hallmarks of Alzheimer's disease. They're more likely to have a high burden of Lewy bodies, which is the pathology in Parkinson's disease. We've shown associations with brain blood flow and vascular health as well as brain atrophy and interestingly neuroinflammation. So we have some new data showing associations between disrupted sleep and more inflammation in the brain. Beatrice's final question is what can she do to improve her sleep, and will improving her sleep ultimately help her memory and prevent dementia? Now, there are some basic keys to healthy sleep that we should really all be doing, right? So some of the keys to healthy sleep are establishing a relaxing pre-sleep routine, keeping a quiet, dark sleep environment, is not using the bed for anything other than sleep and sex. Like, don't do your work in bed. Like, don't sit there and doom scroll on your phone, in bed. Like, no TV, none of that stuff. And avoid, snacking in the middle of the night. It's a nasty habit and makes it really hard to get back to sleep. As important as what we do at night is what we do during the daytime, which is getting regular, moderate exercise, getting adequate outside time, and avoiding excessive napping. So this was like a huge issue actually during the pandemic. So during the pandemic, I had a ton of patients who, because of pandemic restrictions, just weren't getting out, right? They weren't exercising, they weren't doing the things they normally do, and that made a huge difference in people's sleep. A lot of people's sleep got worse in that context. And I think that, like a really important message is that regularity is key, right? So you want to keep the same bedtime, you want to keep the same wake time, and you want to keep the same meal times every day. But sometimes that isn't enough, and I think in Beatrice's case, maybe that's the case. So she has circadian rhythm dysfunction. Her body clock set a little bit early. And one way to address this is with light therapy, with getting more bright light at night to try and push the circadian rhythm a little bit later. So that you get evening light here in front of you, one of these light boxes, and it pushes your body clock and realigns it with the day-night cycle. So will this prevent dementia? So we have a study ongoing right now with Dr. Manuel Montero Dasso at Western, where we have a bunch of folks at high risk for dementia who are being randomized to either an educational intervention or a more intensive intervention, among which is phototherapy for circadian rhythm disorders. So we hope to get results. This is actively enrolling right now, and we hope to get results in a couple of years' time. And the last little bit for this talk, sleep apnea, will treating sleep apnea help? Any of this? So we just completed a study where we took a bunch of folks with sleep apnea, with relatively severe sleep apnea. All were treated with CPAP, which is a standard treatment for sleep apnea. It's a mask that helps you to breathe at night. And then we did brain imaging and cognitive testing before and after. Some of the people, anybody who's ever used CPAP knows it's not that easy to use, right? And some people are able to use it, some people are not. And what we did, among other things, was take a look at these holes in the brain. So there's these perivascular spaces that increase in Alzheimer's disease, and there are these channels that play a role, we think, in draining kind of like the toxic materials from your brain. And when they plug up, they kind of get enlarged. So what we found was, and this is a work of one of my students, so what you found was that when you compare people who use CPAP and not, and by use CPAP, I mean use CPAP for at least 4 hours a day for at least 5 days a week. What you found was that the people who didn't use CPAP had further kind of enlargement of these perivascular spaces, so their channels were getting kind of all clogged up, but that this enlargement was arrested in people who were able to use CPAP consistently. So this is kind of early kind of signals that treating sleep apnea is kind of helpful. What happened to memory? So what we found too is that people who use CPAP consistently had a bigger improvement in their memory than people who use CPAP kind of inconsistently, less than 4 hours a night. So what do I see, as the future? So let's say Beatrice is coming to my clinic instead of 2024 and 2032, 8 years down the road. So when she's still cognitively well, she comes and sees her family doctor for sleep difficulties. Rather than sending her to a sleep clinic, right? Her family doctor gives her a little cloth headband to wear at night, maybe some stickers to place on her chest, and maybe a wristwatch or something like that. She gets the results almost right away, right? Because of machine learning algorithms, and that suggests that she has advanced sleep phase, as we think, and sleep apnea, and also changes in her brain EEG that suggests that she might have a higher than average risk of developing dementia in the future. So her family doctor then is able to use this sort of AI-guided phototherapy and CPAP for sleep apnea, and Beatrice's sleep is now much improved without ever having to see me or another or a sleep clinic, and she lives for many, many years as cognitively sharp as always. All right, thanks a lot, guys.
Okay. So can everyone hear us? My name is Yona, and Aideen and I are going to be talking a bit together about a project that we're doing. And we have just a few slides, but we'll try to tell the story of why we're doing this project and a few things we're learning. and I'll just talk while the slides come up. So, we're doing a study, a project. It's called Brain Health for All, and it's focused on people who have developmental disabilities as they get older, as well as their families. And it's a cross-Canada project, and we're really quite excited about it. Here's a beautiful illustration that was actually created by one of the people involved in our program. So when we talk about for all, we're really emphasizing how we work in partnership together with people with lived experience of having a developmental disability as well as with their families. And we sort of thought, well, what does brain health actually mean? And we got together and we spoke about what it meant. And it's a beautiful illustration that Judy was actually doing while we were having our Zoom meeting. So we had all these different people giving their ideas about what brain health meant to them. And this is what Judy created. I guess I just want to say that even if you don't know someone with a developmental disability in your life, you may be someone with an experience of not just thinking about things like dementia or brain health, but thinking about other things that might be going on in your life that also might make you feel like you're at greater risk. And that's certainly the case for people with disabilities. So in our program, what we're doing is we're teaching people with developmental disabilities and families and service providers who work in health and in social services how we all can improve our brain health. So if we go to the next slide, we really wanted to highlight here that sort of all teach, all learn philosophy. And I think we're seeing a little bit of evidence of that today. I know we had some really important words from a daughter of someone who had dementia, and then also listening to the important story that we heard just before. In our program, these are some of the people who are thinking about what brain health means. And we don't have to identify each person in terms of what their role was, but we recognize that to figure out what we're going to teach, we have to talk to the people who are having those experiences themselves. And we have to be really gentle about how we do that, trauma-informed and thinking about these are not easy things to talk about. And sometimes the resources we have, they just don't land well. So we have to work together with people to figure out how do we adapt them to the people that we're working with. So, Aideen, I know you have some thoughts on that as well.
Thanks so much, Shona. And you know, one of the first questions we were asked as a team is what brain health means to us. And it's a really good question to think of, and it's everything. And as an aging care partner, my ability to advocate for and with my son is totally dependent on my brain health. My physical and my mental flexibility all rely on my brain health. And even though my son and I are both very much impacted by the social determinants of health, our resilience and our ability to deal with these determinants and to go ahead and progress in our lives and find meaning and to really make valuable contributions in life all depends on our brain health. And at work here at CAMH, where I work for Fiona, mental health is health. You'll see that everywhere here. Well, brain health is health. And I think we're moving on to the next slide now.
Okay. So I'm going to talk now a little bit about the blurring of the roles and the multiple kind of hats that we wear sometimes. So you see here the three different groups that we're targeting in our intervention. So self-advocates is the word we use for people with developmental disabilities who are in our program, and families, and of course service providers. But it's sometimes not so neat where we're just one of those things. So I'm a scientist and I'm a clinician, and that's the role I play in the program. But I'm also a sibling of someone who has a developmental disability. We have another clinician in our team whose father, maybe recently had a diagnosis of dementia, and they're figuring out what that means and what that's going to be. But also the people with disabilities, the people we're thinking of as the patients, they have family members in their life who they're, scared about and trying to understand who might have dementia. So we're often kind of working together. We don't just wear one hat. And I think that's a really important thing to think about in the programs that we do.
That is such an important component, and I'm obviously going to be speaking about the context of care partners, as that's what I am, and I'd like to bring what we can bring as care partners to teams, to agencies, to clinicians, to organizations, And we are the constant in our loved ones' lives. We're the liaison between all of the agencies, the practitioners. Sometimes we're an administrator, sometimes we're a personal assistant, a friend, an advocate, an interpreter, an entertainer. We organize things. And looking from a clinical perspective, in a direct observation, you get a snapshot, don't you? You get that moment in time. Same thing with agencies. You see the client where they are at that very moment. As a caregiver, we have their story. We know their context. And without that knowledge of the backstory, I'm wondering if you can really give a true trauma-informed practice without really knowing it. You can guess, you can use your intuition, but I think this is where we can rely on care partners to give that story, providing the relevant data. We can then share the prologue, the antecedents, and the full history that underlies the person. And now looking at what care partners get out of this process, speaking personally, when we're part of the circle of care, we feel validated. When we feel validated, our loved ones also feel validated. We're so interconnected. And ideally, the other thing that we get is we see the humanity of the clinician. We see the humanity of the agency. And speaking personally, it means so much to me when I see vulnerability, when I see the humanity, and I see that the people that are loving or caring for my loved one have as much of a vested interest as I have, that they really care, they want things to work. And now I just want to look at one other aspect of the care partner, and that is in peer support. And we owe so much to Yona and the Israeli team really for providing wonderful opportunities for peer support workers. And many of us that have been navigating a journey supporting an adult who is neurodivergent for a long time have lost trust in the system. Sadly, many of us believe that the system has let us down, that professionals have let us down, that the experts maybe have let us down, and trust has gone over a long time. But in partnering with caregivers, a lot of other caregivers feel a sense of trust. They feel a shared experience. And I think that that in itself necessitates a need for care partners working together as in peer support, as teachers, as mentors, as part of lived experience. And it authenticates our experience together, and many other care partners feel safer with this shared experience and might perceive us as a parallel colleague. And from a systemic model of leadership, lived experience partners within an organization, we could be considered servant leaders. And just picking up on my drop papers, I'm a bit spatially challenged. So in a sense, we just throw my stuff all over the place. This is what I do when I'm on stage as well, I'm sad as a performer. So we are leaders together. It's servant leadership. It's not that kind of demographic pyramid of the top down. So I will hand over to Yona now about multiple roles.
Yeah, I'm going to go right to the end, I think, just to talk about one last point, and then we're going to wrap up. So we could talk about this for a long time, but we won't. So the flyers are a bit ahead. This is just showing all the people on our team. If we go back for 1 second, I know people saw that slide before about the emergency tool. I just want to make one point about that. When we talked about that, we said this is a tool for the patient, right? This is for the person with a developmental disability, if they're aging, if things are going wrong and they need help. And a family member said, what about the tool for me? And it made us think, what about tools that people need to have together, right? Again, thinking about a team, what are our plans? How are we preparing? And how are we working together in terms of how it's not just one person who needs help, right? And having those dialogues and thinking about new resources where people can come together is really important.
So I'd like to share with you actually right now a personal experience, and this is about blurred roles. And my son has given me permission to share that he's in hospital at the moment following a psychiatric emergency. I was allowed to be with him during the emergency process, and I was there as his microphone as opposed to being his voice. I was his interpreter, his advocate, his comforter. And when he settled into his unit, one of the first things that he said to me is, "Mom, I hope you don't get dementia." And even thinking about that now really brings tears to my eyes, because he's desperately afraid of what's going to happen, what will happen for him, as much as he's very valued with the people that he lives with and the people that support him. It's quite frightening to think about. And there's a blurring of roles. This is a huge element, and there's also a blurring of roles right now, for instance, I'm hearing impaired, and this room is an absolute nightmare for me. So I can't actually hear conversations, even with my hearing aids at the moment. When we go out, my son's my interpreter, and he is speech impaired, and what he does is he will often text on his phone what a salesperson has just said to me, and I will then tell him the answer, and he'll text it back, and it takes a really long-winded thing, and we support each other, and this is part of my own aging process, and my hearing is getting worse and worse as I age. Now, at the moment, dementia is not a factor, but looking at the trajectory of his life as one that is bipolar, one that is autistic, looking at my own trajectory of clinical depression, this is frightening. It's a really frightening place to be. And our roles blur. And I just wanted you to be aware, really, to be sensitized and aware of how these roles can overlap with each other. Yeah.
Thank you for sharing, Aideen. We are going to wrap up. We will have information about our program outside, but I think our last message is that we're all actually very layered, complicated people with lots of things going on, and we need each other, and we need to be supporting each other. And partnerships, seeing that humanity, and also the different roles of the clinicians, the providers, the researchers, and the people with experience is really important. So thank you.
Thank you.
We have been hearing all morning about dementia, about mild cognitive impairment, about what we can do to help to improve our brain health. And I'm Allison Sekuler. I am the President and Chief Scientist at the Baycrest Academy for Research and Education, as well as the President and Chief Scientist at the Center for Aging and Brain Health Innovation. And what we're going to do for the next few minutes is have y'all play a game that is teaching you about brain health while improving your brain health. So it's really meta. And so this game we created in collaboration with these genius fellows in Ottawa, who, how many of you have ever played the game Wordle? Okay. How many have you played the game Sudoku? Okay. Do you know that there is a Canadian version of both of those games now? The Canadian version of Wordle is called Canoku. And it's basically the same thing as Wordle, except the color framework has a lot more red in it for the Canadian flag, and it has Canadian-themed words. So my start word for Wordle is always plate, because that's what I'm told is the best thing for using in Wordle. But I always use maple when I'm playing Canoku, because it's Canadian. And when you solve the Canoku solution, it gives you a little fact about that word. And I'm learning so much all the time about Canada, weird little facts about Canada, but really interesting. And so if you're living here in Canada, I'd encourage you not just to play Wordle, but also to play Canoku. Later, they created this other game. You can maybe guess what this one's called. Instead of Sudoku, it's called Canoku. And also, instead of having numbers, it has icons, like little images. And the thing that's so cool, and this is what struck me about this game, was my mom she's about to turn 84. My dad's about to turn 85. Both still in quite good health, and they're both very, very active, physically, cognitively, and so on. My mom plays all of the word games all the time, but she hates Sudoku because it's got numbers in it. And I keep telling her, it's not math, it's just using numbers as placeholders. So what the brilliant guys in Ottawa did who created this game was they substituted those numbers, 1, 2, 3, 4, 5, 6, 7, 8, 9, with Canadian icon symbols like a hockey stick and a jar of maple syrup and a polar bear. And so even my mom will play that game because it's got nothing to do with numbers now. And so what we did was we said, hey, why don't we take that Kanoku, that Sudoku game, is it working? Or why don't we take that Sudoku game and we can turn it into a brain health edition using icons where each icon is telling us something about what we can do to change our lifestyle to improve our brain health. So for us, what the game has in terms of the icons are a brain, which signifies cognitive engagement, a bed, which as you heard from Dr. Lim, is related to sleep. We have an eye and an ear because sensory processing is really important. And we have someone's bicep because exercise is important. We have people showing social interaction, and on and on. And so what you do, if we can figure out how to show it on the screen, no?
I don't think it's going to work.
Okay, so what we can do then is, who has a phone with a connection that they can use? Anyone have a phone? If you have a phone, you can go to the website, okay? If you go to brainhealth.kanoku.ca, and we'll have outside during the next break, we'll have a QR code and the link at the Baycrest table for you. So it's brainhealth, one word, .kanoku.ca, okay? And let me know if anyone's got there yet. You can take a look at it. So brain health is one word, and then .CANOKU, Kanoku.ca. Okay, everyone there? Have you got there? Sorry? Yeah, it's the same link. There's just different ways to get there. But do you see something that looks like it has a brain and different things? Yeah, okay. So what you'll see then is it will have, just like in the normal Sudoku, if you don't know the rules of Sudoku, I'll explain it very quickly. If you have, the simplest case is a 4x4. So there's 4 different quadrants with 4 different squares. And each of those quadrants has to have one of each of the 4 symbols. And each row has to have one of the 4 symbols, and each column has to have one of the 4 symbols. So I'm going to go to this now also, and I can play along with you. Go to the 4x4, and then what you'll see also is that there's a little green icon in the upper right-hand corner. So you can select 9x9 or 6x6 or 4x4. Let's go to the 4x4 beginner. Okay? So what it should look like, you probably can't see this from here, but it has 4, if you are in the right place, you'll see 4 Canadian flags and 3 beds and 3 brains and one bicep. Can anyone see it? Yep. It'll look like that. So the way that you play the game is you click on an empty space, just touch it, and then you click on one of the icons that's on the bottom, and you say which one is missing. So if I'm looking at this 4x4 under beginner, it has, in this quadrant, it already has a maple leaf flag, a bed, and a brain. So what's the missing icon? There's 4 icons. There's the maple leaf flag, the bed, the bicep, and the brain. So the bicep is missing, right? So now if you click on the bicep, it fills in, right? And then you can see going across the top, you click on this empty space here, and if you go across the top, it's flag, bicep, brain. So the missing one is bed. So you click on bed. And now that there's 4 beds, you'll see some little maple leaves all celebrating for you on the bottom when you push it. And then similarly, you can go in and fill in the others. And then once you finish, what you'll see is it gives you, your brain health is boosted. So you've just done good for your brain. You've been cognitively engaged. And it gives you an option of trying other ones, another 4x4 at a different level, a 6x6 or a 9x9. So we wanted to share this with you because, and you can also see there's also a link to go to our Defy Dementia program, which I'll talk about in a moment. And we wanted to share that with you because, again, it's a fun way of engaging your brain while you're learning about what you can do to engage your brain. And so if you go to the 9x9, you'll see all of the different icons. There's sort of 9 different factors that you can look at for ways that you can be engaging your brain. So we wanted to just share that with you, and then I think we have a few-minute break while we're working out the computer for the next presentation. So just you can stay at your tables, play with the game, and again, at the proper break, we'll be showing the QR code so everyone can download it or just can link to it at any time. Every single day, there are 15 different versions of this that you can play, and it changes every day. We've had tens of thousands of people playing this since we released it a couple of months ago, and we'd love to have all of you join in and let us know what you think. So we'll keep playing your game, keep engaging your brain, and we will be right back. All right, welcome back, everyone. I hope you have had a healthy and nutritious lunch filled with nuts and berries and dark leafy greens, all sorts of things that are good for your brain. As I said before, I am Allison Sekuler. I am the President and Chief Scientist at the Center for Aging and Brain Health Innovation, as well as at the Baycrest Academy for Research and Education. And Baycrest is one of the organizations that's part of the Toronto Dementia Research Alliance, along with CAMH, and I can't name them all, so Sunnybrook and Ontario Shores, and I'll let you tell them all. But each of us has a slightly different focus for the kind of work that we do. And the work at Baycrest in our research institute, the Rodman Research Institute, is really focused right now on what we're calling precision aging. And our goal is to use precision medicine, the precision medicine approach, to do for aging and brain health what it has done over the years for cancer. So when I was growing up, if someone was diagnosed with any form of cancer, you didn't even talk about it because whether it was breast cancer or prostate cancer or any other sort of cancer, it was effectively a death sentence, and there was so much stigma associated with it. But over the years, because of the approaches of precision medicine, and what I mean there is like understanding what is your environment like, what's your body like, and how can we adapt things for you versus you versus you, we now know that there are more ways to reduce your risk for cancer, to catch it earlier, to diagnose it in a really precise way, and to treat it. And that's what we're aiming to do at Baycrest. We want by the year 2050 to have no new cases of dementia being diagnosed, nobody moving into long-term care because of dementia, and nobody dying from dementia. And I know that that sounds like a really ambitious goal, but I feel like if we don't shoot that high, we're not going to get even close, right? So that's the goal for us. The one thing that's a little bit different about our approach to precision medicine in aging and brain health compared to the standard approaches in cancer is that in cancer, people typically think about precision medicine helping more in the diagnostics and the treatment side. Whereas at Baycrest, what we're really focused on is the entire sort of lifespan, if you will, of aging and brain health and dementia. So starting at prevention, what is a personalized way we can create, say, a personalized longevity, a personalized brain health prescription for you? And that would be different than it would be for you or for you. So how do we help each person prevent dementia to the best of their ability? How do we detect it as early as possible and have the right kind of diagnostics to make sure we're diagnosing as early as possible what form of dementia it is? How do we treat it in the best way for that individual? And how do we care for people in a really personalized way who are living with dementia. So we've got these 4 buckets or pillars, if you will, from prevention, detection and diagnostics, treatment and therapeutics, all the way through care. So in a nutshell, that's the kind of work that we're doing in our research at the Rotman Research Institute at Baycrest Academy. But we also are very, very much committed to this idea that it's not enough just to publish papers in Nature and Science. It's not enough to advance the science even. It's not any good unless we get it into the community, unless we're sharing the knowledge with others. And that's what I'm going to talk a little bit now about today is our Defy Dementia program, which is really about sharing knowledge with people about what are the lifestyle changes that you can make that will reduce your dementia risk or slow the progression of the disease if you've already been diagnosed. So I just want to give a shout out to team members. There are a number of team members spread throughout the room, and there were more at our table if you saw them during the lunch break. So maybe just Baycrest and Cabby people raise your hands so people can see who you are. So there's a huge, huge team that's been involved in this Defy Dementia project. We have just a couple of the folks here. And if you listen to the podcast, there's somewhere we thank everybody. But it's not me alone. It's not Jay Ingram, who's my co-host on the podcast, the two of us. There is a huge team of us working on it together. And the initial funding was from the Public Health Agency of Canada. So I'm just going to quickly go over a little bit of background on dementia and the prevalence, and then we're going to get into the risk factors. And I'll show you a little bit about what the Defy Dementia program really is like. Before I get started, I want to just find out a little bit more about all of you, right? So can you raise your hand if you are a scientist? Okay. Or including trainees. Trainees, you scientist in training, that counts. Raise your hand if you're a clinician. Okay. Raise your hand if you're a caregiver. Okay. And raise your hand, well, you don't have to raise your hand, but if you want to raise your hand, if you are living with dementia or have been diagnosed, you're welcome to raise your hand. No requirements, obviously. Okay. So, and raise your hand if you've known somebody at some point during your life who has been a caregiver or living with dementia. Everyone's hand probably is going to go up at this point. So dementia, as that you've already heard earlier, is not just one thing, right? People often will think it's Alzheimer's disease, but it's actually a term that covers a lot of different kinds of disorders. Alzheimer's is the most common, but it also includes Lewy body disease, vascular dementia, frontotemporal dementia, Parkinson's-related dementia. There's a whole bunch of other sorts of things. There's HIV-related dementia, et cetera. So, and often there's more than one kind of dementia that's built into this. It is right now affecting over 50 million people, and the rate of people who are being diagnosed with dementia is increasing. So every time I'm snapping my fingers, which is about once every 3 seconds, somewhere in the world is a new dementia diagnosis, right? And as the world is aging, you can see what's happening, right? Because age is the biggest risk factor for dementia. Now, the prevalence in Canada itself, you can see all dementia cases from about now, which is on the far left, all the way through 2050. You can see it's expected to grow from about where we are now at about 750,000 up to almost 2 million people within Canada if we don't do something to slow the progression of this disease. In Ontario itself, as I mentioned, age is the biggest risk factor for dementia, and this is part of the issue for us is that if you look on the top, you'll see that the numbers of the people in this population over 85 and even over 100 is growing much faster than it is in other parts of Canada. So that's increasing our lifespan, but also our risk for dementia. And then some of the factors that we know can increase your chance of dementia are shown on the bottom. The good news for Ontario is that some of those risk factors like heavy drinking, obesity, smoking are actually lower in Ontario than they are in other parts of Canada. But notice the physical activity. Canadians who live in Ontario are experiencing a much lower rate of appropriate amounts of physical activity than they are in other places. There was a question in the sleep session with Dr. Lim that people were asking about folks up north. And I was just up north, not maybe as far as where it's 24 hours, but we were just up in Whitehorse doing some presentations with folks in the community there. And what was interesting there was, yes, they might have longer days and might be a little bit harder to sleep, but their physical activity is much higher, right? So there can be these trade-offs. And when he was saying, well, yeah, they maybe don't sleep as much, but maybe they're exercising more. So there can be these kinds of trade-offs. Now, these are the most recent list of risk factors, one of the most recent lists of risk factors for dementia. There are some things that we can control, and there are some things that we can't control. And again, we've talked a little bit throughout the day about some of these. Age, your sex, your genes, those are things that right now you can't really control. So women are more likely to be living with, say, Alzheimer's than men, and it's not just because they live longer. And there is a risk factor associated with certain sorts of genes, particularly for certain kinds of dementias. But what's really interesting is that at least 40% of the risk factors for dementia are things that you have control over in your everyday life, right? So some of these are things that start earlier in life, like your early childhood education. Some are things that can start to change during your midlife, 45 to 65, including hearing loss. We heard recently about hearing loss. The good news is, for example, and we'll come back to this, hearing loss, if you're working on it and you're treating it and you're using your hearing aids, then that actually seems to decrease your dementia risk, so that's great. And then there's other things in later life that seem to be these risk factors as well, and we'll talk a little bit more about some of those. And you know, one of the things that we wanted to do was to let people know that there are things that you can do to decrease your dementia risk. There are changes you can make in your life to reduce your risk or to slow the progression if you've already been diagnosed, right? And so that's really what the Defy Dementia program is all about. And what Defy Dementia is a multimodal knowledge mobilization extravaganza. Is that a fair way of putting it? So it has a podcast, it has infographics, it has short 1-minute videos, it has a website with resources, it has the game that we showed you earlier, and it also has an amazing co-host, Jay Ingram. Has anyone heard of Jay Ingram? Raise your hands, yeah. So Jay Ingram, and he and I are the co-hosts of the podcast, and we're very fortunate to have, as I said before, a great team, including Ben Schaub, who's over here. Ben, raise your hand. Who's worked with Jay for decades, I think, three decades, at Discovery Channel and so many other places. So adding a level of professionalism to the podcast that we definitely wouldn't have had without. And the way it works basically is that each of these podcasts has focused on a different risk factor for dementia. So the first one was focused on sensory loss, your hearing and your vision. We covered loneliness and social isolation, cognitive engagement, exercise, nutrition. Episode 6 is just me and Jay having a conversation about our New Year's resolutions, what we're going to try to do to change things. And if you listen to that one, I am sleeping a little bit better now, so don't worry about me. Environment, including air pollution, sleep, and actually Dr. Lim was our guest on that one of our guests. Keeping it simple is sort of a summary of where, catching up on where we were. Stress, there was a question earlier in the morning about caregivers, and there are some statistics for people who are caregivers for folks living with dementia that you can be up to 6 times more likely, it can increase your risk by up to 6 times, but that's not, as you said, I think before, it's not because it's contagious, it's because if you are a caregiver, you're taking care of someone else instead of taking care of yourself. So the main point of that one really is take care of yourself as well. We have our next episode coming out soon on genetics. And I just want to show you very quickly, if you're not familiar with podcasts, what some of these look like. So if you go to the Defy Dementia website, which is shown here, it will take you to the landing page for the very last episode, right? So that's shown here. And our last episode that I mentioned was caregiving. And I want to go to the first episode, which is sentences, so I just click there. And then it has a summary about what the episode is about, some key takeaways, highlights, quotes from the different guests that we had. It has a very brief animated 1-minute video, and it will have an infographic, and I'll show you those in a sec. But I'm not going to play the whole podcast, obviously, but just so you can hear a little bit about what it sounds like. This is the very first episode
my brain was muddled, and I was calling it mental fatigue. I would get home from work, my husband would look me in the eye and he'd say, yeah, you're toast. You've spent too much time trying to listen today and trying to understand.
That's Laurie Harris. She's a British Columbian with a compelling life story about how partial deafness has impacted her life and her brain. You'll meet Laurie in a moment.
So each episode is starting with, or typically is starting with a person with lived experience. And we heard how important it is to hear the stories directly from people with lived experience. And then we have a scientist or a clinician listen to that story and respond to it and provide more information about what's happening in the brain related to that particular risk factor, and more importantly, what can people do to decrease their dementia risk. And one of the things that I mentioned is to understand hearing loss. Just as a little aside, if you're interested in whether you might have hearing loss, we actually have a free online screening tool at Baycrest, and we can make sure everyone gets the link for this later. It's absolutely no cost. You need to use headphones because it tests each ear separately. And just a little quick aside on this, last time I visited my parents, they'd been married for, 50 years or something. I thought they might get divorced because they were just fighting all the time. And it turned out it was because they're both losing their hearing. So my mom would be like, Robert, you're mumbling all the time. And my dad's like, Sue, you never do what I ask you to do. And I said, you guys can't hear each other. So I had them both take the hearing loss. My mom now has hearing aids, and there's marital bliss once again. So it's worthwhile taking that test. In terms of the videos, this is an example of what one of the videos looks like. This is the first one from Vision and Hearing. So,
vision and hearing changes are a part of life. Those changes in your hearing, or vision, can greatly increase cognitive load.
In other words, when it becomes difficult to hear or see what is happening around you, more mental effort is needed for hearing or seeing, leaving fewer cognitive resources available for other things, like remembering what you heard or saw.
So what can you do? Take sensory changes seriously. Even if you don't think you have a problem, get your vision and hearing tested to establish a baseline, or to know if things have changed for you.
If they have changed, use hearing aids or glasses to decrease your cognitive load. By doing so, you can continue to engage with the world around you and decrease your dementia risk.
So each of those episodes has just a very brief 1-minute video, and that little brain character shows up in every one of them. You get kind of attached to that little brain guy who's going around. And then we also have an infographic for each one. This is the top half of it, which talks about what is the issue, and then also importantly has how can you take action. Because again, we don't think that understanding what's coming out of the research and the science is useful unless we give people advice on how can they take action in a way that's going to make their lives better. For folks who are francophones, we have it also everything's in English and in French. So feel free to, if you're not a francophone, actually learning a second language can be good for your brain. So you can sort of listen to everything in English and then in French. And you can access all of these again for free, just at defydementia.org. Or if you're listening to podcasts, you can just go anywhere that you get podcasts, Apple Podcasts or Google Podcasts or Spotify, wherever. We're everywhere. And a shout out to the team because the podcast actually was nominated for a Webby Award this past year. Thank you. But I'm a dual citizen. The Canadian in me says, it's an honor to be nominated. The American says, I wanted to win. But we were in the same category as Sanjay Gupta, so guess who won? But that's okay. But I think just being nominated there, I think for us it wasn't so much about for us it was really about raising awareness about this issue of dementia and aging and brain health and what we can do to help people learn how they can take control of their own lives. You can't necessarily prevent dementia for sure, but you can do things that are going to slow the progression of the disease. You can do things that are going to decrease your risk. And one of those, as I mentioned before, is cognitive engagement. So if you didn't get a chance to play the game, you can scan the QR code or just go to brainhealth.canoku.ca. And that is everything I wanted to share with you today. So thank you very much.
Hello, everyone. How's everyone doing? We have heard a lot of different experts, researchers, just talking about the different aspects of dementia. And there are a lot of different studies that are being talked about. And have you ever wondered who actually participates in these research study? And also how to do that. If you have been asking those questions, this is what we're going to be talking about at this panel discussion. So in the next maybe 30, 40 minutes, we are going to have a little bit of a structured conversation with Brittany and Ian. We'll introduce them a little later. And we are going to talk a little bit about, some of the aspects of dementia research. What is dementia research, right? What types of dementia research are there? Can I be part of it? And what are the questions to ask if a study is actually a good fit for me? And also, we are going to hear, from both Brittany and Ian, their role in terms of managing and coordinating and the engagement in research in dementia. So we're going to. I'm the moderator, so I have to do the slides as well. So there we go. So my name is Mary Chiu, and I am actually a research scientist based at Ontario Shores Centre for Mental Health Sciences. Anybody know where that is? No? So we are similar to CAMH in a way that our focus is on, on mental health, and we are a hospital that's located east of Toronto in Whitby. We have very nice grounds there. It's right by the lake, and we have facilities for different units for geriatrics, for adult psychiatry, and also for geriatrics. So that's where I am located. And then we also have our panelists, Ian Goldman and Brittany Prokop. Here they are. So I'm going to let Ian and Brittany introduce themselves briefly. Maybe we can start with Ian? Yeah.
Hello. There you are. It's an English accent, so get used to it. I'm going to be talking more slowly than some of the people have done this morning. And judging by the number of caregivers here, I think that's going to be a good thing. I myself was a caregiver to my mum in the north of England over her 8-year journey with dementia. I'm her only kid, and living here in Canada, I'm proud to tell you and happy to tell you that it was possible to do that distance caregiving over using the internet, of course going over there once a year and having a couple of really good supports, which I'm sure all of you involved in caregiving know is very, very important to your loved one, but also to yourself. And my wife is here today, and she was, of course, one of my supporters. During that time, I thought it was important to learn as much as possible about dementia. So I became involved with the Alzheimer's Society in Toronto. And for those of you that don't know, they are an outstanding organization and a great deal of help to educating, providing peer support to caregivers and to their loved ones. As I learned more, I was able to understand more about what was going on with Mum. The other thing that helped is that I'm actually an engineer by background. So all these new developments with therapies, with devices, apps, tools, methods that have been coming out for the last 10, 15 years, I started to get very involved in, and my wife actually spotted an ad to participate in learning about these devices through Baycrest. Baycrest actually has a center for innovation in aging and brain health. It's called CABI, and I was one of the starting members there. Alison heads that up, amongst several other things. She's gone.
No, she's still here.
Okay, I was going to talk about her, but now I can't. So my participation in CABI has also given me a great deal of information. Accordingly, I have been participating in research activities for about 6 or 7 years, and I'm going to tell you some of the good stuff, and I'm not going to be shy about telling you about some of the wrinkles as well.
Thank you, Ian. Brittany?
My name is Brittany. Some of you may know me. I'm a research coordinator with the Toronto Dementia Research Alliance. My role mainly involves connecting people who are interested in participating in research with research studies happening in our network. So our network being the 6 hospitals that we're exhibiting outside. We have a website that I'll go into later, but this is my main role. Professionally speaking, I have a Master's of Science degree from the University of Alberta, where I studied stroke, and I also spent a couple years over in Scotland studying autism spectrum disorders and intellectual disabilities before moving to Toronto. And on a more personal note, I love to cook. Me and my husband really like to try different types of produce and find good spots. So if you know any good farmers markets, please let me know, because I'm still relatively new to Toronto. And we try to travel when we can as well. Personally speaking as well, with the Dementia Connection, we are currently trying to get a family member assessed to see if they have dementia possibly. So this is the start of my potential caregiving journey personally. We'll see how that goes.
Thank you, Brittany. So as you can see, like we all wear different hats. Professionally, we can be doing things that are related to dementia research. We also bring in a lot of lived experience, maybe, as a caregiver or with, someone living with dementia. And so, very quickly, who I am. I also wear a lot of different hats. So together with my dad, I'm actually a long-distance caregiver for my grandmother, who resides in a long-term care facility in Hong Kong, quite far away. And I provide support to my father as he navigates the different aspects of caregiving, and I also act as a sounding board for him as he has to make decisions. Professionally, I'm a research scientist based at Ontario Shores, and I lead research initiatives aimed at co-designing Meaning, like I work with different knowledge users, caregivers, community representatives to build different programs and innovations to support a caregiver. And then I find a lot of joy in being an educator and mentor as well for students from different disciplines and ranging from social work to psychology to computer engineering and science. There are a lot of, just next slide. A lot of you contributed to those, writing on the post-its on the dementia research is. These are not actual answers, but like as I was preparing for this slide, I put a little bit of examples of what dementia research really is. From your perspective, from the participants' perspective. And I'm going to read, some of, if that's okay, to read some of the responses. So dementia research is investing in your future, is community and partnership. It is very important for progress. It's very necessary. And it's needed in areas such as Lewy body dementia. Dementia research is intergenerational, and it should involve patient, caregiver, friends, etc. Dementia research is exciting, but it is slow on knowledge translation and implementation. Dementia research is a significant part of recovery and should include caregiver mental wellness. Dementia research is not widely available or accessible. And then the last one I'm going to read is, it is often the subject of stigma. So hearing all of these, I'm just going to post it to Ian and Brittany. What do you resonate with when you're hearing those responses? And what may surprise you?
So I actually took those down and I took a sneak peek at lunchtime there, and some of those were really, really interesting to me. Specifically, the one about research not being accessible or widely available. People don't know about it. They don't know where to look for information because this is my job. I connect people who are interested with research to studies, but what I'm currently trying to really push is spreading the awareness of our research tool. So this is one of the reasons that we are hosting this, is to let you all know about our research tool, where we list studies and you can browse at your own pace and then express interest, be connected with the research team directly. The other one I thought was really interesting. I think the caregiver mental wellness, because lots of people don't realize that we have studies for healthy volunteers. We have studies for caregivers where our researchers are studying caregivers specifically, or the caregiver person living with dementia relationship. So those are the ones I definitely resonate with.
Great. And Ian?
So holding right there.
Use your mic, Ian.
In your blue brochures, your blue folders, there are 2 brochures on the inside, and one of them actually speaks to the tool that Brittany is talking about. It's called the
Toronto Dementia Network website. Thank you for saying that, because it was in my notes to say it and I forgot. So yes, it's the more green brochure. The dark blue one is the Toronto Dementia Research Alliance in general, but the Toronto Dementia Network one is the more green kind of one. Sorry for red-green colorblind, but.
Yeah, Brittany is going to talk a little bit more about the Toronto Dementia Network, near the end of the our discussion here. But Ian, did any of those responses resonate, surprises you?
Several. And didn't they really cover a wide range from the optimistic beacon of hope, which we're all hoping for as for our loved ones or for ourselves, to the other side. I love the statement about stigma, because we know the image of dementia and Alzheimer's just a generation ago was one of fear. How do I speak to people living with dementia? Those poor caregivers, how are they managing? Nowadays, that stigma is starting to reduce. It's becoming much more comfortable to talk about these things. Intergenerational, I heard that. And yeah, we are seeing people the age of Brittany finding themselves, and younger, not that she's old, young people in their 20s becoming involved as caregivers to people who are perhaps in their early 50s who are developing young onset dementia. Yeah, it's becoming an intergenerational situation. And finally, before I get to the best one, caregiver mental health. I know personally, and I'm happy to talk to anybody that's got questions, how demanding caregiving is. And if we can't be at our best, how can we help our loved ones? So if you come away from this as a caregiver with anything, it's look after yourself. Watch out for yourselves. The one that resonates strongly is a beacon of hope. When 20 or 30 years ago you had a diagnosis of Alzheimer's or dementia, it was not a great prospect. But these days, with some of the treatments that you've heard about this morning, some of the devices that we haven't had a chance to show you today, but take a look. We'll give you some resources where you can take a look at some of the things that are being tested and tried, which I've had the chance of giving feedback to. There are some wonderful smartphone-based apps, things that you can wear on your body, things that can be put into the home. We talked about sundowning this morning, so light improvement, some marvelous innovations. There is a competition worldwide at the moment called the Longitude Prize in Dementia. It's going to be worth $2 million to the organization that can come up with a new tool that will follow an individual's path through their journey in dementia, and it will adapt to them as their journey changes, as the symptoms change. The prize will be announced in 2025, but there are 23 semi-finalists right now from about 10 countries around the world. I'm actually lucky to be on part of the panel involved in that project. If that isn't a beacon of hope, then what is?
Thank you. That was a very sort of like important message right there. It's, this morning, I remember Dr. David Tang-Wai was saying, if, you have been diagnosed with dementia, that's not a, you continue to live life. And there are so many different innovations and technology that is, and programs that are actually supporting how you can continue with a good quality of life when you're living with a condition. So that's that's a very good sort of opening to our sort of understanding of what dementia research is, and just some information about the different the main types of dementia research as we're talking about. And you heard this morning, there are different types of research, but I'm just going to say there. It can fall like in two categories. One is more of the observational study side of things. So like these are not interventional studies. So like you're not assigned to an intervention group, and you may be, if you are participants in these kind of studies, you may be observed like over a period of time. Let's say like if you exercise, and so like people would the researchers will look and follow you for a period of time to see if the level of exercises is going to be associated or can explain the risk of being diagnosed with dementia, something like that. So observational study, and then there are clinical trials where researchers will actually assign participants to different interventions. So it can be behavioral interventions, it can be surgical, it can be innovation that Ian is talking about, and testing the effectiveness of these different interventions. And there are different types of clinical studies, and I'm just for the time being, I'm just going to show you the two non-drug and also drug sort of clinical studies. So as I was saying, there is going to be the behavioral and lifestyle intervention, and then the some of the kind of clinical studies may involve the more sciencey things, the looking into the makeup of the amyloid and in the brain, and circadian rhythm, so like looking at sleep patterns, etc., etc. So there are different, the reason why I put these types, up is to show you that there are so many different kinds of studies, and Brittany is going to talk a little bit more about it, and how they're being organized within the Toronto Dementia Network. Okay. No. And I'm going to wrap this section up by saying it is very important, for us to consider participating in dementia research. And people usually participate in research because they want to contribute to discovering information that may be, helpful for others in the future. Some people, they are motivated because they want to play a more active role in their own health, and learning more about, what they can do to improve their wellness. And then there are also, different treatments that they have tried for their health problem and may not work. And so they wanted to try different things. And in any case, we are all partners in scientific discovery as we participate in research. So what would support research participation? And we have heard from some of you. Some of you may have completed a survey to help us understand, what actually will help or facilitate your participation. And there are different reasons, and I think I'm going to point out the top three. If you have a lived experience of dementia, either as a caregiver or someone living with dementia, you would want to kind of contribute to the knowledge creation. And people are also saying, compensation to participate in the study would also facilitate opportunity to participate in webinars, and learning about the results of the study is going to help, and then using the study results to influence your lifestyle changes and things like that will also help. I'm going to go to the barrier before I go to our panelists. So there are close to half of you saying that if I don't know what is involved or what is the ask, that is a big barrier. Does that resonate with a lot of you? Yes? No? Okay. All right, so I am going to start maybe by asking Brittany, what are some of the things that TDN and TDRA have put into place to help address some of these facilitators and barriers that our audience is telling us?
Yeah, so having lived experience is one thing. I mean, yes, you have a personal level of motivation at that point, but we do have studies for healthy volunteers as well, and we get people signing up who are, they just turned 19 or something, and they're like, well, I don't have dementia, but I'd be interested in learning more. And we do have studies for all adults 18 and up, including healthy volunteers. Compensation to participate in a study. So this is important to a lot of people, as you're dedicating your time, you're dedicating your experience, essentially. So this is study specific. Each study will have a different method to compensate depending on what they are asking you to do, how involved it is. Many of them will have compensation in the form of taxi chits, for example, like to help with transportation. So that was one of the barriers, I think. Taxi chits, TTC tickets, sometimes they'll reimburse you on mileage, and gift cards, different forms. So that's very study specific, and you can always ask me or the study team for those details before you decide if you actually want to sign up for the study. This is a normal thing to ask. It's completely valid. And then for the opportunity to participate in webinars or workshops to learn about study results. So we have a number of knowledge translation products. We partner with the Alzheimer's Society of Toronto to host webinars about these studies so that you can learn more. And we also have a monthly newsletter where we will describe a new finding, a new study in the field in that newsletter. And we also have blog series that also talk about the research that's happening in our network as well. So there are some resources out there to help introduce these items about learning about what the results are. In terms of the discouraging items, I already talked about transportation, but what is unclear about what is involved or what is the ask? And again, that goes back to our TDN, Toronto Dementia Network recruitment site. We post all of those studies in plain language. We review them, the researchers send them to us, and we will edit them and tell them to change it because they're talking about biomarker, like very specific biomarkers, like people don't need to know the specific biomarkers at the point where they're just inquiring. So we try to put it in plain language as possible so that you can understand when you're browsing yourself for those studies. We also outline what the time involvement is, what they are actually going to ask you to do if there's an MRI involved, if there's a blood draw involved. That will all be listed there. And if you're not sure, my email is associated with that website. My phone number is associated with the website. You can call and ask or email and ask. That's for me.
Great, and let's hear from Ian. We do have, the practical things that you can do, and Brittany is always here to answer any of your questions. But Ian, tell us your journey in terms of being, engaged in research. How did you, you alluded to it a little bit when you were introducing yourself, but can you, I know there are a couple of things that really motivated you in participating in research, dementia research. So can you tell us a little bit about that?
As well as my own personal connection with caregiving with my mum, other people I've worked with on research, they are motivated by, they're going to make a difference. They are participating not just to be like a guinea pig, but they want to make a difference. They're going to offer knowledge and experience that they've got that these bright younger people have not heard about. And the bright people may come with tremendous ideas about a new drug or a new app, but they haven't lived the life of someone with dementia or their caregiver. And I'll tell you, there's nothing more rewarding than when you tell them about a situation, an instance, and they say, oh, we didn't know about that, or we're going to have to rethink based on what you've said. Then you know you've left some footprints in the sand. The other thing is that working with bright people of a younger generation is very stimulating. And if you are moving towards retirement, even if you are working full-time as a caregiver, and it's a full-time job, you can get some joy and refreshment of working with these folks, and most of them are very caring. All of them are very caring about their work, but they're very caring about the people that they're participating with. You don't end up like a guinea pig, where you're just being offered a medication. You are involved in the actual study. You can help them think through their results, planning their next steps, helping them to think about additional services such as transportation, or some of these folks are hearing impaired. They'd like to have closed captioning, if you could do that. Joe, did you know Joe really likes a cup of tea at 3 o'clock in the afternoon? Can we provide that for him? I'm going to take a walk and see if I can get some cues. Okay, so we've talked about how I got engaged. All of those things I've just mentioned to you enticed me into this world. Do you want me to talk about my impact so far, or have you got some other
I think you mentioned, your involvement in developing, like a participation guidelines for, both person living with dementia and caregivers, and also for the research teams, in terms of supporting, the engagement. As a researcher, I'm always curious to hear, what can we do to better support research participation? So maybe you can comment on that a little bit.
One word: ask. Ask. And Brittany will give you some initial answers to the question, what is this study about? What's it going to involve? But then you'll start to meet the research team. Ask all the time. There should be a document at the outset called Terms of Engagement. Get a chance of looking at that, and if there's any term, any technical expression on there that you're not sure about, keep on asking. You're going to learn something, it's going to help you down the road, and you may stimulate them to say, oh, we should be explaining that better.
For sure. That's actually one of the things that we had a conversation when we were lining up for lunch, and I was inviting Ian, if he would be interested in, joining us on, an advisory committee. And the first thing that he asked is the term of reference. And I'm going to be providing that for him, for sure.
That's right.
Yep. So, okay, so we are going to, just go into the last section here. It's, after hearing, all of that, you may be interested. So what's next? I'm going to let Brittany talk a little bit about the Dementia Network, Toronto Dementia Network, and how it works.
Thank you. So one thing I did want to add, I realized with the transportation limitation, I forgot to say that we do have studies that you can participate at home. You can the researcher will go to your home and visit you there, or we also have virtual ones. So getting into this though, I have notes to make sure I take you through this in detail and I don't miss a vital part of the process, so that you are all aware of exactly how to access this. So again, this was created in partnership with the Alzheimer's Society of Toronto. And if you're asking if you'll get the slides from today, we are recording the event. We will post it afterwards, and we also have some documents for key takeaway messages as well. These slides specifically are also always shown at the beginning of our webinars that we host in partnership with the Alzheimer's Society of Toronto. I'll tell you about our next webinar at the end of this, where this is also on our YouTube, and you can always access this information, or email or call me as well. So this is the webpage link. It's also in your brochures. This is a website where you can browse studies at your own pace. There are studies for people living with dementia, mild cognitive impairment, those at risk of developing dementia, and healthy volunteers as well as caregivers. To get started, the website link can be found in your brochures or on this slide. On the website, next slide please. On the website, there are two main pathways. First, you can browse for a study using search terms, filters, or quick searches. When you find a study you're interested in, you can fill out the contact form to be connected with the research team who will enroll you in the study if you are eligible, or answer other questions. Or at the bottom, if you're not sure where to start, you can fill out a questionnaire to be matched to a study, and any information you enter will be securely stored and protected. Next slide, please. So this is what the website looks like. When you're on the page, if you're looking for something specific, for example, Alzheimer's disease studies, you can type it into the search bar along the top. You can either hit submit with that term, or you can apply more filters like the type of study, the age group, the target population, or the study location, and then hit submit. Alternatively, you can also use the quick search buttons that we have in the blue boxes. If you'd rather fill out a questionnaire to be matched to a study, you can click the Match Me to a Study quick search box or scroll to the bottom of the page, and you'll see the orange button that says Can't Find a Study You're Interested in, which will also take you to the questionnaire. Each study summary, as shown on the left here for the VR Sim Cares study, describes what the study is about, who can participate, the location, and the time requirement. Again, all in plain language. Next slide. So to help promote this recruitment site, we host webinars with the Alzheimer's Society of Toronto, where researchers discuss a study on the site, and viewers have the opportunity to interact with the researcher and ask questions. Please note, they're not just talking about the study, they talk about a general topic to do with dementia as well, and then they'll talk about the study that relates to that topic. So our next one is on May 21st at 2 p.m. And Dr. Mario Macelis will be speaking about how genetics relate to Alzheimer's and other dementias. If you want to register, the link is on this slide. You can also find it on our website, which is in your registration materials. So the TDRA website, on the events tab, you'll find it there and you can register. And then next slide. Perfect. So this is a slide showing you how you can connect with us. You'll see it again in the closing remarks, but the left side of the page is how you can contact me specifically, our TDRA general email, the TDN website, and that phone number is the research phone. So that goes to whoever is monitoring the research studies page. So if you have any questions, call. If I don't answer, leave a message. I will call you back.
And that is going to be the key takeaways. That are people going to be getting the key takeaways? Yes. Okay. Just to go very, very briefly over it, as potential participants, if you are interested in any of the study that is on TDN, don't be shy to ask. There are different types of studies that may benefit from your input and participation. You're, engaging in co-design and as a partner in a scientific discovery. I'm going to say. Leave the last word to Ian, actually. So there may be people who may be interested in participating. As an expert, what can you say to them?
I would like to actually ask if there's time for any questions about anything we've said. Do we have a few moments? Okay. Any questions? Do we blow
Any
them away?
questions? Don't be shy to ask. Allison.
Please state your name before you.
Ian, what's your favorite experiment that you've ever been in, and why?
Too many?
Well, that's right. There's good technology, Alison, and there's soft spots. Okay, I'm going to give you 3. It's got to be 3. Soft spot. An innovator of a new program came to us. The program is aimed at promoting, so this is a program, this is not technology, promoting social connection between young people and older adults to improve social isolation. And of course, the pandemic really brought this to the fore. And this young person from the University of Alberta had come up with a concept called Sunshine Connected, by which they would match candidate older adults with candidate young people for trading information, exchanging knowledge. I took part in the pilot of this, exchanging my knowledge of travel in certain countries with her knowledge of a piece of software that would be really, really useful to my personal life. So we met 3 times over Zoom. She's in Alberta, I'm here, and they were structured. We were matched extremely well from interests that overlapped. The 3 sessions were beautifully structured by the organizers, and this program is now going on. We piloted it. It's now with the feedback that we gave, it's now going on to be rolled out across Canada. There you go. We made a mark. The one I'm most proud of is working with the new memory program for residential care at a very well-known location in Toronto. They want to build memory care for people living with memory problems it's not an institutional setting, but they're in a protected community. They want it to be person-centered care. Each individual has their own care program to Mosaic? Yeah, thank you. Which aims not to focus on their disabilities, but on their possibilities. It's called the Possibilities Program. They called for people who have lived experience with a loved one, and they showed us, 3 of us, different ages, different situations of caregiving. They showed us how they were proposing to design this care document for our loved one, which would be the basis of their care and which would change as the person's journey with memory changed. This program has been adopted here in Canada. It is being prototyped in Thailand. It could be a global program, the Memories Possibility Program. I think I'll stop there.
Thank you, Ian. I hope that, what we presented and talked about today inspires you and motivates you to find out more about how you can engage in dementia research. And I thank you for Ian and Brittany for your input and wisdom. And I thank you all for your time.
What a day. Just some closing remarks. Am I moving the right way? I'm not sure. Thank you very much for being here today. I'm Tarek Raji. I'm the Executive Director of TDRA, and I'm really privileged to be here and have you all attend all these hours. So many rich information, so many questions, I think, and information that if you want to ask about, please reach out to any one of us. I want to thank you again for being here. I want to thank all the presenters today and the speakers, really great presentations. I want to also acknowledge and the team who organized all this behind the scene. Ruth, standing behind me. And Brittany, Winnie, please stand up so you'll know where you are. Winnie in the back, and Dorcas, I'm not sure if it's outside. So it's running everywhere. So thank you very much. Great preparations. So as mentioned before, the presentation will be recorded and be available on our YouTube channel and website. You will receive a follow-up email with the key points. Some of them you've seen already with also helpful links and survey, and the value of, emphasizing the value of participating in dementia research. I think the way to advance knowledge and to discover the new treatments cannot happen without all of us participating in all of our different roles we heard about. And again, so many ways to connect. Pick up the phone, look at our YouTube, check our website, join our Twitter, or X actually, previous Twitter. So many ways, and this is also, please let us know how the day went. Give us your feedback. Until the next one, thank you.